Today we're going to have a discussion about cumulative dose monitoring. More specifically, the importance of monitoring cumulative dose in addition to the barriers to doing so and potential ways to overcome those barriers. Over the last few years, ONS has learned a great deal regarding cumulative dose issues from the over 50,000 students who have taken the ONCC Chemotherapy and Biotherapy Certificate course. Some of the key things that nurses have identified as barriers or challenges to cumulative dose monitoring include assuming that it's someone else's job and not the nurse's job, not having access to the cumulative dose, patients getting treated at different facilities or at different times in different facilities, belief that it's not really part of the nurse's role. Someone else is doing it, the pharmacist is monitoring it, or the physician, and nurses not even knowing where the information is recorded. To start off, we're going to talk about the importance of cumulative dose. Why is it important?
Sure. So let's start off by discussing the importance of cumulative dose. Katie, do you want to talk about that?
Yeah, sure. So cumulative dose is the total amount of drug that a patient has received over the course of his or her lifetime. And there are several agents in which there is a maximum dose that they can receive over the course of their lifetime to avoid different toxicities. One of the most common examples of this is with doxorubicin and the cumulative dose risk for cardiotoxicity associated with that drug. The lifetime dose for doxorubicin is 550 milligrams per meter squared, unless they have received chest irradiation or are getting concomitant cyclophosphamide, in which case the cumulative dose decreases to 450 milligrams per meter squared. Another example of an agent with a maximum cumulative dose would be bleomycin, and we don't want patients to get any more than 400 units of that drug over the course of his or her lifetime in order to avoid pulmonary fibrosis. There are other agents that, while they may not have a maximum dose, there is increased risk for other toxicities as they get more and more doses. Vincristine is a good example of that type of drug, and the risk for neurotoxicity increases with each subsequent dose of vincristine. The anthracyclines have a risk of cardiotoxicity, but the dose at which that would occur may vary from agent to agent. But these are just some examples of why it's so important for nurses to be involved in tracking the cumulative dose of that these patients receive.
So this brings us to another question. Are nurses responsible for this information? Should they be calculating it? Should they know where to find the information? Should they review this information?
Chris, would you talk about that?
Absolutely. Looking at cumulative dose is definitely part of the nurse's role in checking the 5 rights of administration, the very basic steps that we all take when giving drugs. One of those rights is making sure that you have the right dose, and cumulative dose is part of that.
Okay. So are there standards out there that discuss this? Can you elaborate on those standards?
Sure. In 2008, ASCO and ONS collaborated to create the first chemotherapy administration safety standards. And these standards really look at the entire process of chemotherapy administration and where checkpoints and safety monitoring areas need to be included. One of those is a requirement that cumulative dose be tracked whenever institutions are administering those drugs that require it or that it's part of. And this is not only for ASCO and ONS, but also other professions have required that, such as pharmacists have it in their standards as well.
So now let's talk about some nursing assumptions that we have learned from the course. So the ONCC Chemotherapy and Biotherapy Certificate course, showed us that nurses knew that cumulative dose monitoring was important, but they kind of assumed that someone else was probably monitoring it, maybe the physician or the pharmacist. Mm-hmm. So Katie, can you talk about that?
Sure. I think it's so important that we as nurses never assume anything, especially when it comes to patient safety. And Chris, as you discussed, tracking the cumulative dose is absolutely part of the responsibility of the nurse. And yes, we have heard multiple times that current systems usually have the pharmacist or the physician accountable for holding that cumulative dose documentation. And so it is easy for the nurse to maybe feel like, well, I don't have easy access to that information. It's not part of my process. It's not my job. But we absolutely have seen that it is. And as you said, the standards that are out there for nurses support that as well. So there is recognition that maybe this makes one more step for the nurse to try to get a hold of the pharmacist, try to get a hold of the physician in an already so busy environment. But skipping steps with patient safety is not something that can happen.
So what are the implications if the nurse doesn't monitor, doesn't take that extra step to get that information?
Right. So what we know is that if you're involved in administering the dose of drug that happens to take them over that maximum cumulative dose, the nurse, as well as any other healthcare provider involved in that order, are equally as accountable. And so education is so key, so that all healthcare providers know that we're equally accountable for tracking these cumulative doses, making sure we're keeping patient safety a priority, educating the patient that you're receiving a drug that we need to track cumulative doses, and really advocating for some system-wide changes to make this more readily available for the nurse.
So the many nurses who have taken the ONS-ONCC chemotherapy and biotherapy certificate course brought up many barriers, some of which we have already discussed, regarding monitoring cumulative dose. Now I want to discuss, a few of those barriers and perhaps ways to overcome those barriers. One of the biggest ones that we've heard about through the course is the electronic health record, and either not having access to it or not knowing where to find it. So Chris, do you want to talk about those a little bit?
A lot of the challenges facing nurses with electronic health records regarding cumulative dose are first that the inpatient system might be a little bit different than the outpatient system, and they don't communicate with one another. So you may be following it on the outpatient side and have no knowledge of it on the inpatient side, at least in the nursing part of the documentation. Also, some nurses have identified that when they're in their EHR, say on the inpatient side, they're able to see a lot of the patient's chart, but they're not able to see the cumulative dose information. It's kind of blacked out for them. So that's another challenge. And also that it's not even in the system. In some cases, pharmacy might have a different computer system than the clinic or the inpatient unit, and they can't follow it because the information's simply not there. And that's when they have to directly communicate with the pharmacist for the information.
So, what can they do? We did learn, a few things from the nurses that took the course, but what can they do to get that information?
Well, nurses are experts at building workarounds. They tend to create paper charts or shadow charts, which you really like to avoid doing because you want the information communicated to everybody. But something on paper that some people have used to give a copy to the patient or have a chart that can go into the hospital or out to the clinic if the patient is moving around. It's also helpful to have that paper card or something that the patient can have for their own, saying how much they have received. And this is often in survivorship records when someone has finished their treatment, or if they're traveling, they can know what drugs they're currently taking. Also, in the computer systems, some centers have put in alerts or have posed the idea of alerts, similar to when acetaminophen dose is being maximized. They get an alert that you can't go over this dose. So that's a helpful approach. But most importantly, I think nurses really need to discuss it with their leadership. Nurses need to be able to have access to the data that will help them provide the safest care to the patient that they possibly can. So to be able to open up that electronic health record and make sure that they can view all the pertinent information. And also to have it be in one place. So everyone in the institution looking for the information knows where to find it, and they go back to that same place each time.
But now let's talk about, some of the more patient barriers. We learned from nurses who took the chemobio course that, they referred to these patients as snowbirds, those patients that come south, for the winter. They may be in the middle of treatment, they may need treatment or get diagnosed and need treatment there. And, there's also those patients that have had treatment
A long time ago, and how do we handle those kind of barriers, is what we probably should discuss next. So, Katie.
Yeah, this probably happens a lot more frequently than we'd even know about. So, in addition to the snowbirds that you brought up, there are certainly a lot of patients who maybe start their treatment with one physician in one practice and transition to a different practice with a different physician, partway through treatment, or, so I think this is definitely an important concept for nurses to consider, and the whole healthcare team has to know that they have thorough and accurate records if they're going to be able to assume accountability for that cumulative dose tracking. We also have to think about, are we getting thorough past medical history from these patients? The patient might think, sure, I had breast cancer some time ago, but I haven't been treated for years, and it might not even dawn on them that they need to bring this up, and this is truly a calculation over the course of a lifetime. So there's a lot to consider in making sure that we have thorough and accurate records so that we can know that we're being comprehensive with our cumulative dose tracking. And so the nurses who have taken this course have done really a great job with giving us some ideas for how they've overcome these barriers. And one of the things that we heard was this idea of, could we build a national registry? And so, you'd record in this national registry what doses of chemotherapy each patient has gotten. And while that seems so huge, and the scope of that seems really large, and is this even feasible? We like to encourage, think big, think out of the box, and that's not a bad thing. That can really lead to some big changes within your institution. We'd also want to think about building these types of things into survivorship care plans. And as we as nurses are building care plans for our patients, making sure that we have included in that what doses of chemotherapy they've gotten for which malignancies, and things like that can really help the patient track these things over time as well. Which leads into the importance, again, of patient education. And we really need to empower our patients to know you are getting a chemotherapy agent that has a maximum cumulative dose associated with it. And it's really important for you to know this and, to advocate for yourself. And that's our job as nurses, to help educate the patients that, it's not just the system's responsibility, but there are some other, extenuating circumstances that we need to account for.
So thank you, Katie, thank you, Chris, for such a great discussion of the many barriers to cumulative dose monitoring and ways to overcome them. Nurses are at the forefront of ensuring patient safety. We must step forward in a leadership role to foster a culture of safety with chemotherapy and biotherapy administration. Nurses need to discuss these issues with their leadership and talk to them about their ideas to overcome the barriers that we talked about today. Be a catalyst for positive changes to occur in your facility in the name of patient safety.